Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to episode 35 of the now #1 on medical coding and billing search on iTunes, Codecast Podcast. I love saying that. The #1 anything is always exciting. And we just hit #1 on TuneIn for the same search. And so we're moving up in the world. I feel like I need to play some background music on that. But we're pretty excited about that. And I really appreciate our loyal listeners and any of the new listeners that have come on board. I've gotten a lot of social media feedback on my Instagram account, TerryNCA, and on my Twitter account, TerryCoder1. So just the engagement of all of you really makes me happy. So thank you for everything and really the support of our Codecast podcast. And so we're pretty excited to bring you this each week. And you should know we're very consistent. You will see this drop every Tuesday, 5 a.m. My producer is, Joe Kuzma. He's awesome. Gets it out there on every platform. Plus now we're on YouTube as well. And then there's something new on Instagram called now Instagram TV. And I think we're going to do a couple of live spots on there just in case you're like, I'd like to see Terry live a little bit and see what's going on. I haven't been able to get to a live conference, so we'll kind of see what's happening there. But first, we want to say the Codecast podcast is brought to you by Medical Economics, Smarter Business, Better Patient Care. Follow us for the latest news and viewpoints on primary care, the business of medicine, and health IT. Check out our website to access our virtual magazine publication at www.medicaleconomics.modernmedicine.com. Smarter business, better patient care. And then also ICD-10 Monitor, a division of MedLearn Media. It's an online news and information service created to help healthcare providers in all settings make informed decisions relative to coding, clinical documentation integrity, CDI, value-based purchasing, and other new payment methodologies. ICD-10monitor.com reports on all current issues, including population health, physician engagement, and the patient experience. ICD-10monitor.com. Okay, so a couple of things I want to address before we get started. And for those of you that have been following this for the last 7 months that we've been on the air, you know that it's the last Tuesday of the month. And so we will have Top 10 Tuesday, which means those are my top coding questions I've received through email, through practices all over the country. And we actually had quite a bit of pickup this last week or two just in not only downloads, but in clients really reaching out for services. So we appreciate that. We've had 5 more on-demand coding corners. I actually tweaked something on my website where we have code books on there. I don't know if you're aware of that, but we have a couple code books on there, and just for cardiology, GI, ortho, different specialties it's more of a workbook, so you can actually write into it, but it's on PDF, and we've had a lot of people, as soon as we put it on the products page and not on the services page, everybody's able to find it, and we've had a lot of people wanting to purchase that this week. So we appreciate that, absolutely. So thank you again for your support. But a couple of things, and I feel like this is my page 6 correction today. So last week I addressed a few things when it came to simple mistakes. And then at the very end, as you know, at every Codecast podcast episode, I comment on a coding question and just kind of give you some insight. And what I did last week is I did some misconceptions and cleared up a couple questions on transgender coding. And I had such a positive on that. But at the very last second, and this is me, I guess I was talking a little fast, and that does happen, the very last 4 seconds of the podcast, and I didn't catch it when I always preview, but my music and content producer, Desassin, he caught it, and I basically said something twice the same. So let me clarify. So procedural coding, what I was talking about was there's no specific procedure code for people diagnosed with gender dysphoria who are choosing to transition. There are 2 CPT codes that pertain to intersex surgery. 55970 is intersex surgery male to female, and 55980 is intersex surgery female to male. And so just make sure that you know that I think I mentioned both of them were female to male. They aren't. So the first one's male to female, the second one's female to male, and that I just misspoke. So I apologize for that, but that's why you have an edit button. And my edit button, his name is Desassin. So he's not only my music producer, he really picks out and helps me choose music, not only for this show, for also when I do spots on XM radio, but he also is my content, kind of my Jiminy Cricket, I call him. He sits on my shoulder and says, yes, that sounds great, but Terry, don't do that again. Or this sounds good. Yeah, let's skip that. So without that edit button or that person, really kind of coming in back of you and making sure things are good, you just never know, what is in there. So I appreciate his input as well. Okay, so we're going to go ahead and get started today. And we're all over the country with questions. So this is kind of a fun part. We have some different questions and different responses to those questions. And they're really all over the place. And I think some of them you'll not only be able to relate to, but you'll be saying, oh my gosh, I had that question. I didn't know where I needed to go to get that answered. So the first one comes to us from a Minnesota client, and it says, good morning, Terry. I just finished reading your article on ICD-10 Monitor, Auditing Issues Uncovered in a Physician Documentation, Part 1. It was actually a 4-part series, just a little side note there. She says, thank you for writing this and for being a great resource as a Coding Corner member. I have a question. After reading your article, I started thinking about red flag issues at a new gastroenterology practice that I'm now working for, and I could really use your advice. So here's what's happening. The medical team adds ICD-10 codes and submits claims for breath tests using the same 2 ICD-10 codes for all patients. But when it's not indicated in the physician documentation, I'm concerned. They told me they were given a cheat sheet which directs them to this, and they've always done this and shouldn't worry about it. And I shouldn't worry about it. I reviewed the cheat sheet, and it directs them to use the same 2 codes, but because those codes are and they directs them there because those codes are more likely to be reimbursed by Medicare and the insurance companies. I'm concerned that overusing these codes, 1, will spark an audit, 2, the documentation may not support the ICD-10 coding, and 10, the cheat sheet will be a big problem if we get audited, and 4, we're going to have to pay a lot of money, right? Are my fears warranted? Any advice on what I should do? And thank you for taking the time to read this. Okay, so I know that was a little bit of a long question, but as soon as I heard the word cheat sheet, the hair on the back of my neck stood up, and I'm sure it did yours as well. I've done a lot of depositions as an expert witness, and I had to sit in on different court cases, not only as an advocate for a physician, because I am absolutely a physician advocate, but also on a payer side on certain cases. And I don't like it when I have to do that, but the payer isn't always wrong. And so we have to keep that in mind. If they were always wrong, then we could get paid everything we billed. And let's face it, billing professionals and coding professionals wouldn't be necessary. But we have to look at this from reality standpoint. And first of all, who are you trying to cheat? We never call them a cheat sheet. If you have reference guides or tools that you use so that you have macros or certain places you can go so you don't have to always look up, okay, I can see that kind of thing. But don't call them cheat sheets, and they actually shouldn't be used that way. Secondly, her comment that they're using certain codes because that's probably more likely to get paid versus what was actually documented. Well, that's to me is not even something to respond to as far as the answer to that. I know that she was trying to get information, and I commented that I was going to put this on the air. She was trying to get information to make sure she could bring it back to her physician, so it wasn't so much on her. But if you don't find it in the documentation, you can't code for it. And that's the ABCs of not just auditing, but also of coding. And so that is a huge problem. So I truly believe that this person needs to go back and have a meeting with their physicians. And I feel bad for her because as a new staff member, having to right away point out some things that are a problem and are non-compliant, I just know that's going to be an issue. Number 2 is from a Florida client, and it says, hi, Terry. My physician was very interested in starting the process of telehealth in our office after listening to your podcast on the topic a few weeks ago. I let him know that you offer webinars and training sessions on the topic, but he just wants to bypass it and bill for a phone call for a patient as a new patient of the guy's telemedicine. Can you please help? Okay, this has been a huge topic this week because the Office of Inspector General, so the OIG, Their website puts out some of the new things that people are getting in trouble for. And actually they put out something on telehealth because it is really the wave of the future. And that's why I've done so many webinars and educational pieces on it, and 2 podcasts. We had one in November and I had one last month, only because you just need to keep hearing about the topic. We're probably going to have another one at the end of summer about the new stuff that's coming out. But here's the thing. So because this is such a hot topic, OIG put out something saying that over 50% of telemedicine services are being reported incorrectly. So what they said is that means there was no originating site, only the distant site, which is who consulted the patient. They also said that there was a problem with HIPAA secure equipment and internet connections, which doesn't surprise me. Telehealth is a new delivery of medicine and can be an added revenue source for your practice, but only if you don't jump in head first. Okay. It's called easing into the process. So get educated on the process and make sure you have the rules in writing. This is what keeps you compliant and out of the watchful eye of the government should they ever come in and you need to justify why you build something a certain way. So you need to be educated on the topic. What I've tried to do is really bring from a telehealth webinar perspective. That is where I tell you, okay, this is the code you need for the originating site. This is the code that you need for the distant site. And here's how you deal. And this is who's eligible in between. What the webinars or what the podcasts have been for is this for you? Should we just dive into it? What are we looking at? Pros and cons. So listen to those first and then say, okay, I could see this or not see this for my practice, and then take an educational piece on it so you have all the paperwork. That's what I would recommend, because there's no way really out of it. You're going to have to do some kind of telemedicine at some point. The next one, number 3, is from a California client. It says, hi, Terry, our physician says he stays late for a lot of patients after hours and should get paid more for doing that. What are our options for coding, and should it just be upcoded from our current level of service? Okay, no upcoding here. So I know it's tough when the cost of doing business spills into the off hours for physicians. But first, I would first make sure that you're scheduling staff. Treat the physician's schedule as you would see any restaurant or bar or just place of business. You want to make sure that if you're open 8 to 5 or 9 to 6, that you have a last call scheduled, last appointment scheduled. Patients should be 20 minutes before you close. So you're not scheduling. If you're open 8 to 5, your last patient isn't at 5. It's about 4:30, 4:40, unless it's a new patient, it's at 4:30. An established patient, you could be 4:40, 4:45. But this allows the staff, while that patient is in there, to finish up their administrative end, close out the day, reconcile the money, while the physician sees their last patient. Remember, your office hours, again, doesn't say we see patients from 8 to 5. It says you're open from 8 to 5 or whatever your hours are. It is also recommended that you have 1 to 2 nights a week that are flexible. So try at least one 12 to 8 shift or one 7 to 4 shift. Patients will absolutely appreciate that flexibility, because now you've kind of spoken to them and their schedule, because they can make that appointment before work or get there after work, because they're working in a place that's probably also open the same time. Now, as far as your question goes, I wanted to preface with that. There is a code 99050 that's in the miscellaneous section of CPT, and it states 99050, and I'm quoting, services delivered in the office outside of regularly scheduled office hours, in addition to the basic service, end quote. But so far, very few payers even consider this miscellaneous code for payment. Medicare does not reimburse for that, and that doesn't mean you can't charge for them. It does mean you can charge for them but you have to charge everybody. Unless it's a B status code. So let me just explain real quick the difference between B status and non-covered services. Seems like I'm doing that a lot this week. A B status code means that a service is bundled, and that's a Medicare rule, but other payers use it as well. So for example, let's say cardiology. They have an intervention code for a stent, 92980, that's old code, 92928. And then they have a code for a branch. Let's say you're in the left anterior descending, but you're in the branch of the left anterior descending artery, so maybe the diagonal one. And then let's say you also stented the diagonal one, which would be 92929. Well, the add-on codes for that, the branch codes, are in a B status code, meaning that Medicare and the payer already believes that you've been paid for it. Bundled means it's inclusive, meaning you've already received money. The value of your main code is already paying you for the extra code. And so that's what bundled means. It means if you try to bill it again, you're basically saying that you're double dipping. Now, are there edits to unbundle certain codes? Yes. But if it has a 0 on the correct coding initiative, that means it cannot be unbundled. Now, coming back to your question as far as the outside regularly scheduled office hour code, that's a non-covered service. So can you code for it? Yes, you can code for services like that, but you can't just bill it for patients that you know their insurance will pay for it. One of the things with healthcare that is missed, I would say, on half the practices in the world, in the country for sure, is the fact that if you can't hope to get paid. You have to expect to get paid. So anytime you're putting out and reporting a code to a payer, whether it be Medicare or a third-party payer, you're putting it out there because you're expecting to get paid. And so you have to treat every patient the same. You can't just say, well, this patient has Humana, they cover it, but this patient has Blue Cross Blue Shield of Michigan and they can't have it covered. That is absolutely unfair, and you're penalizing the patient who has maybe a slightly better reimbursed insurance than the one that doesn't. So make sure you're not doing that. And if it's a Medicare patient, it's a non-covered service. So they just need to be informed as to other patients that you're going to charge this. Do I encourage charging it? I do not. But it's something that you can if you want to. ER doctors do it. Number 4 is from an Oregon client. It says, Terry, we just joined your Coding Corner membership and have not had a chance to ask a question. I will also say it's been years since any of us have been to an educational webinar or a class. Okay. So we have mid-level providers that see our patients, and when my physician is performing procedures in the endoscopy lab. Let me read that again. So we have mid-level providers that see our patients when my physician is performing procedures in the endoscopy lab. So it sounds like a GI practice. The physician insists that these visits be billed out under his UPIN number, so his provider number, even though he is not in the office, but at a facility off-site. Does this sound right? I thought I read somewhere a long time ago that this is not appropriate. Thank you in advance for your insight. Okay, incident 2 rules, okay, and this is a problem. So incident 2 rule means that where does your physician have to be when another provider is in the practice? So that would be a nurse practitioner or PA. So where does your doctor have to be? They actually have to be in the practice. We call it within yelling distance. We did a previous podcast on this. This is a incident 2 rule. So your doctor actually has to be there. If your physician is not there and they are off site, then that's billed out under the nurse practitioner or PA or the mid-level provider. And so you have to make sure that they're not doing that regardless of what your physician wants to do. You can't do that. Now, let's say that you have a mid-level that's seeing a patient in your office and another physician in the group practice is in the practice that day. So whoever's supervising that day actually can get credit if you want to get 100%. If you just want to bill it out under the nurse practitioner PA, then you're going to get an 85% reimbursement. So that's just a rule. That's nothing we can actually get around there. Number 5, a Texas client. It says, Terry, a 68-year-old patient with prostate cancer receiving chemotherapy visits his oncologist to receive a Procrit injection for anemia caused by chemotherapy. How do I code the ICD-10 codes for this? Okay, so what this is going to be is your first code is going to be your D64.81, so anemia due to antiplastic chemotherapy. That's why they're there. C61 is going to be your second diagnosis, malignant neoplasm of the prostate. And then you're going to have a T code, and I like talking about T codes. And this is an adverse effect of an anti-neoplastic and immunosuppressive drug initial encounter. Anytime there is a drug interaction with a patient that's counterproductive or counteractive or an adverse effect, then it's in a T code section, which actually means an injury to. I've mentioned that before. So again, that would be T45.1X5A. The X in there is actually a placeholder, and you need that because you have to get to the 7th digit to be able to give the episode of care, and this is initial encounter. So you have 3 codes in that area that you're going to be able to code for that patient. Okay, so I wanted to bring to you the next sponsor, and so our mid-roll is brought to you by Health Tech Magazine. Health Tech Magazine serves as the leading source of information for forward-thinking professionals involved in healthcare. HealthTechMagazines.com. Okay, so we have number 6, and this is an Idaho client. So our orthopedist performed a joint injection on the patient's left ring finger at the top and used ultrasound guidance. How do I code for that? Okay, first, for our listeners that are not familiar with orthopedics, the proximal left ring finger is called the interphalangeal. Okay, so it's the proximal interphalangeal, that's the PIP. And when injected into the joint with ultrasound guidance, you would use a combined code for the service, 20604, and that says arthrocentesis, aspiration, and or injection, small joint or bursa, with ultrasound guidance for the service. Okay, so whenever you also see and or, sometimes in the knees, they'll want to take out fluid. That's the arthrocentesis, and then they'll want to inject into the knee. You only get one code, so that's why I wanted to bring that to your attention. We have a Nevada client for number 7, and this is, what is the code for moderate sedation for a Medicare patient during a colonoscopy? Our physician spent 15 minutes supervising while Versed was injected. So for Medicare, for gastro, you're directed to a HCPCS code, which is a temporary code, and it's GO500. So if this was a commercial plan, it would be, as you know, the 99152 for the initial up to 15 minutes, at least 10 minutes. But Medicare is tracking gastrophysicians when they're coding for moderate sedation because they're aware that most ASCs, where some of the lower GI endoscopies are performed and upper GI endoscopies, are using propofol, which is a general anesthesia, and an anesthesiologist is usually administering this and the medicine and monitoring, and not the procedural physician. So until they're comfortable that there's not a lot of overlap and a lot of coding being done incorrectly, then they're going to continue to do that. So we just want to make sure we're clear on that. They tend to definitely want to err on the side of caution. Number 8, California client. Terry, I keep getting a denial for this patient. I'm not sure why. So the patient presents to the emergency department, and the orthopedic surgeon, my physician, is called for an evaluation of a patient with a type 1 open fracture of the shaft of the right radius. I coded S52.321A, and I have resubmitted this claim 3 times, and I'm still getting denials. I have the correct 7th digit because it was the initial encounter. Please help. Okay, you're going to need to look at your claim just a little bit closer. Yes, your 7th digit is there, but it's not correct. The correct 7th digit is B. So it is for open fracture type 1 or 2 for initial encounter. That one little mistake has now cost you time and effort in rebilling, and you need to now send a corrected claim. So remember, since this was in the ER, your codes don't match and you're not accurate, so that's why you got the denial. So just remember that A, yes, that's an initial encounter, but if you look at fracture 7th digit codes, those are different than the B is for open fracture type 1 or 2 initial encounter. So I think sometimes we get a little bit complacent by just putting on there a code we know from memory or a character, and we have to be careful with that. So I have a Boston client, Boston, Massachusetts, says, "Hi, Terry, I know this isn't a coding question, but you said we can ask you coding, compliance, and management through the Coding Corner. And you have been so helpful with us in the past, so we would hope that you could answer this for us. I wanted to ask you a question about our AR department. What is the one thing you would tell us to do that could make an impactful change in our productivity and our revenue cycle management process?" Well, the first thing I would do is I would start with tasks nobody likes doing, like fixing data entry errors, creating invoices or statements for patients, or updating spreadsheets. Once you have identified these tasks, look for ways that they can be automated. So one thing, for example, if your AR processes require you to enter output from one software system to another software system, try and see if there's an interface available. Call your vendor to automate this process. So many practices always tell me, wow, we didn't know we can do that. All I can tell you is ask. Always see if you can do it by asking, because that's going to be, really important. My number 10 question comes from Mumbai, India. And so I did have to ask this Coding Corner client if it was okay if I put her question on the airwaves, and I think when you hear it, you'll know why. And I never want anybody to feel like they can't ask a question that's not private. And so if I use your question on air, it may be inappropriate, I did definitely ask you first. If it's just a straight coding question, I want everybody to be able to hear it. But if it's something that I not just was surprised, but felt that it really needed to be heard because this is a pattern I see with other questions, I did contact a person directly, and that's why I don't give any names on the phone. All I basically are on the air. I just basically let people know just kind of the area where it's at. But it says here, and so they know this was going to go on the air. It says, Ms. Fletcher, we are doing coding for cardiology practice in New York, and we're getting denials when we code the heart cath code 93458, saying that we are not using the right modifier. Well, we aren't using a modifier, so what are we doing wrong? Okay, so I'm going to be really sensitive to this question because I know they also listen in, and I appreciate that, if you don't know what to do, find help. That's what I'm here for. But there are going to be times, and I have to tell you, just like my music and content producer, Disassin, did to me, basically said, hey, you made an error there, you need to do that. I'm going to do that when I see some blatant errors. I'm going to just do kind of a light tap on the wrist because you need to make sure that you're accurate. And so I did contact the office I mentioned. So I do have a few practices that have outsourced their billing and coding to other countries whom are not familiar with coding practices. And that frightens me a little bit. So you really do take your chances here when they're not here understanding how things work in this country. I'm not saying you shouldn't use them. I'm just saying you need to do your due diligence if they know your specialty and if they understand coding. So first of all, cardiac cath codes are 2-component codes that require a 26 modifier by the physician when performed in a facility where the physician doesn't have financial interests. You're not billing the global. They are allowed to bill for the professional component in the facility, so they use a TC modifier. And then make sure when you take on any new specialty where you are a billing service here in the States versus another country, it is imperative that you learn about the specialty before you submit claims. This is not only a reflection on your company, but the physician as well. Any false claims, overcoding, inaccurate coding, incorrect coding like this can not only expose everyone involved to an audit, but also can hold up your reimbursement for months. So luckily, I say they were getting denials. Can you imagine if they were getting paid the facility rate for the entire global service? You'd be getting, instead of $300, you'd be getting almost $1,800 to $2,000 for something you weren't supposed to get. So that's where we have to be very cautious about, who's getting some of this service. Otherwise, that can definitely be an issue. Okay, so I wanted to go ahead and wrap up today with just a couple of things here. So what we're coming up with in the next Codecast podcast is I'm not sure if it's going to be next week, but I'm going to talk about HIPAA at some point because we really need to talk about that with regard to coding and how it's affected. And that's really the privacy rules, but I might push that along a little bit. Also, how to go from coding student to coding professional, and then how to go from coding professional to possibly, build your consulting business. I want to help you with that. And then why coding and documentation audits are more important than ever. We've received so many things lately. It's been crazy. And then one of the things I really wanted to talk about as well, people bring up to me all the time, they say, we need a best practices, just really understand what you're seeing in the country and just some different best practice issues. And so one of the things I want to talk about, I've done collections and appeals and revenue cycle management and stuff. So one of the things I'm going to talk about, I think maybe in the next podcast, as best practices to improve patient payments. It's hard to do that. And so we really want to talk about that and make sure that patient payments are also being addressed appropriately. So you'll hear that coming pretty soon. Okay, so we just want to make sure that we hit our last sponsor. And our last sponsor is actually, I mentioned him a couple times today. It's going to be my music producer, Disassin. You can find him on his website at disassinmusic.com. He has a new album dropping on July 13th, and you can pre-order on iTunes or any platform, and you can stream it as well. We got Spotify, and you've got everything out there. So feel free to take a look at that. He's awesome. So hopefully everybody will support not only our podcast, but also our producers that are doing some services of their own on that. So thank you everybody again today for attending, and we hope you have a great rest of your week and make it a great day. This is Terry Fletcher, and I'll talk to you next week.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Disassin Music.